All right. Hello, everybody, and welcome to November's The Physician's Garage. I'm Vineet Tiravati. I'm an M4 down at Emory and Georgia Tech. And today we have John William.
Hi, my name is John William. I'm also an M4 at Johns Hopkins, applying to internal medicine this year.
And today we're going to talk a little bit more, pick up the conversation from our last TPG, and talk a little bit more about the Bayesian reasoning process that we're starting to see a lot more in medicine. How do we reason through different patients, and how do we reason through what's afflicting our patients in a framework that's pretty exciting? And I'll let John William take it away.
So today we're going to just touch on, we'll start with a paper that I think nicely frames Bayesian inference in clinical medicine and clinical reasoning. That paper is titled "Don't Drop the Anchor." It's the first author is Dr. Reza Manesh, who's at Northwestern right now. But it's a great paper, a great case report that I'll touch really quickly on and what the findings were, and then we'll discuss, kind of some of the nuances of how Bayesian inference was used in this paper. So really high level stuff here. The paper presents a patient who presents with painless jaundice. And just to be short, presents with all the social family history that you would just expect someone with pancreatic cancer to present with. A drinking history, a smoking history. And so the clinicians, of course, take this patient and quickly ascribe, on their differential, right off the bat, pancreatic cancer as being kind of the number one on their differential. They go through the whole diagnostic process to kind of determine whether this is, adenocarcinoma or not. Obviously, here the consequence of missing cancer is extraordinarily high. In the case that this is still, stage 1 disease, a Whipple procedure would save the patient's life potentially. So the onus to really make sure it's not cancer is very high in this patient. That being said, the authors have an interesting course of events in this diagnostic workup. What they end up finding is they go through with the Whipple procedure to excise the mass. And the finding is on the pathology that it's negative pathology, i.e. there is no cancer. What they found instead was these IgG4 producing plasma cells. And this really was just IgG4 disease. This was autoimmune pancreatitis that had presented with painless jaundice, which of course this is not your step 2, question, right? If you get a question on step 2 that says painless jaundice, elderly gentleman with smoking and drinking history, the answer is adenocarcinoma of the pancreas. Interestingly, this was a patient who presented with autoimmune pancreatitis secondary to IgG4 disease. And the therapies for these two are very different. Obviously, the prognoses are extremely different, right? One, is quickly fatal, while the other one is not. And so the paper is great because it kind of allows us to take a step back and think through how would Bayesian inference here have been used to help us guide our differential. And like I said, the patient presents with these initial findings, and so the pre-test probability or the initial thought or the initial chances that this is adenocarcinoma is very high. Now, after the Whipple, they did some of the calculations and they kind of computed, well, now the likelihood of being cancer given negative pathology and all the tests they had run was 15%. So not insignificant. There is a chance that the IgG4 disease is a completely, coincidental finding in the setting of pancreatic cancer. That's definitely, a possibility. So there's always a chance that it still could be pancreatic cancer, even if all the labs tell you otherwise. And that's what they kind of infer here, is that this was maybe 15% chance post-test probability. The question is that we want to discuss here, and the paper kind of highlights, is what is the feasibility of doing this kind of inference on the wards? I mean, it's great in the paper to sit down and kind of hunch out the numbers, right, and and go through the math and get some nice, data to work with. But how can we do this in a high throughput manner? How can we do it and does it matter? And I think that's the first thing we'll discuss today is how well does the clinician need to be able to do Bayesian inference on the fly to change diagnostic and therapeutic actions?
Yeah. And that's, we're going to be asking that question, I think, a lot more in the field moving forward as we get more sophisticated inference approaches, diagnostic approaches. The first thing that comes to my mind is there are a multitude of Bayesian approaches. Then there's a distinction between using Bayes' theorem, using the kind of hard math of it, versus this idea of doing Bayesian style inference. They often go together, but they don't necessarily have to. In that respect, I think it's a fantastic question. Do we sit on the wards and work through the math? That's definitely one way of doing something that approaches Bayesian inference. A very different way is, and this is always fascinating because it straddles the world of math, but also straddles the world of engineering. We do things on a gut feeling basis all the time. And there's a way to quantify gut feeling. And I want to open this discussion up with the idea that we are doing Bayesian math, but the we part of that isn't me and you. The we part of that is the frontal cortex and my parietal cortex. That there's this calculation that gets fuzzy, but for the most part, there's a hard number to it. And then at the end of it, we all say, well, is it low probability, high probability, or
In the middle?
In
Yeah,
the middle.
I don't know.
And we broadly, and I think in our lives, just across the board, we split things up into those three broad categories. And if we're talking about doing Bayesian inference in the context of, at the end of the day, there's only really three options, whether for diagnostics or therapy. If there's only three options, what are we doing? How are we doing it? And I don't think there's a solid yes or no answer, but are we doing Bayesian style approaches if we're, at the end of the day, splitting it up into three different categories?
So what's interesting is, I absolutely agree. There's, in clinical medicine, I often think about like PE, pulmonary embolism. And when a patient presents, we usually have three categories. We think if it's a high probability PE, you don't need to get a D-dimer. You don't need to, you just go to treatment. If it's a low probability, also not helpful either, because the pretest probability is so low that a positive result doesn't change your posterior that much. It's really the patients who are in the middle, who are the question marks that we're unsure of, where diagnostic management actually makes a difference to move that posterior probability in a way that will change how we treat the patient. But then the question then comes after that is, well, how low is low? Because I think this paper highlights, yes, given all the data that we did collect and our observations, the posterior was low. 15% is, I think, low. I don't think someone would say that's in the middle, right? But the way we treat 15% probability is very much dependent on what we are treating, right? There's a cost, there's a risk. If this is pancreatic cancer, 15% is high enough where it's not low enough to ignore. Does that make sense, right? And I think that's the question here is we can assign probabilities, but then the value of that probability is tied to the consequence of you being incorrect.
Exactly, yeah. And we're trained on the science side to try to split what's the truth, first figure out what the truth is, and then do your decision making based off of the truth. At the end of the day, as clinicians, we can't do that. We're constantly dancing between understanding what's afflicting, what is the pathophysiology, but also we got to act. And the best case example of this is, like meningitis, right? If there's certain symptoms you see, you go ahead and you start treating. Well, you get your sample first, and then you go ahead and you start treating, and then you let the diagnostic course take its course. I think what you're getting at is crucial, and there is a way to formalize it. I know there's certain Bayesian approaches, like Bayes cost, where you're actually including the cost of making an error into your p-value. Essentially, it's your alpha, right? That that you're actually choosing your threshold. You're almost choosing your p-value based off of the cost of being wrong. And
Hmm.
there are formal ways of doing that. Now, a lot of some people who may be listening maybe get a little bit antsy or awkward at that, and rightly so, because what you're doing there is you're formalizing your subjectivity into your calculations. And how do you formalize that? Do you put a hard number on it, or do you
Hmm.
put a low and a high? So including that starts changing what is considered in a non-Bayesian way your expectation value.
Hmm.
And one example that I like going to about this is, let's say there's a 100-sided die. I wish there was a better example. There's
Hmm.
probably a better example, but there's a 1 in 100 probability that if I just do the 1 in 100 probability, I give you $1,000. Okay, so I just give you $1,000. That'd be fantastic, right?
Hmm.
Now there's a 99 out of 100% probability that you give me $200. Okay,
Yeah.
so what would you choose?
I can roll the dice once.
Once.
I'd take my chances.
You take your chances with respect to what?
Getting my $1,000.
So you would take the 1 in 1,000 to get your $1,000, or 1 in
But
100
that's
to get your
yes,
$1,000.
that's my value. My perception is that I'm not losing that much. If I roll and lose $200, it's not as hurtful to me
As
as
potentially gaining it.
the 1,000. Yes.
Right. Now start moving that 200 to 900.
Then of course,
Then so it's
yeah,
changing. So even though the probabilities didn't change whatsoever, it's still 1 in 100 that you get 1,000.
yeah,
Now it's 99 in 100 that you lose 900.
yeah,
That value, the cost of an outcome, even though the outcome probabilities don't change, the cost of the outcome changes. You start changing your
yeah,
significance value. You start
yeah,
changing your decision making to play the game
yeah,
based off of the expectation value you would get. And all of that is non-Bayesian, right? That's just
yeah,
standard expectation values. Where the Bayesian portion comes in is, how do we actually formalize the idea of the fact that it's 1 in 100 and 99 in 100? How do we include the
hmm,
frequencies into that? So in the case of this patient,
yeah,
have a decent idea of whether it's adenocarcinoma or not. The more we learn about that patient that is potentially unrelated and before the Whipple, should change that probability.
yes,
And the last little bit I would argue, but I'd love to have a discussion about this piece of it, is at the end of the day, your cost of being right and wrong can actually be considered a changing of that decision boundary that we just discussed.
hmm,
So we talked about maybe three broad
yeah,
categories: low, middle, and high. At the end of the day, if a low probability thing has a very, very high cost, like an adenocarcinoma has a 15%, but it has a huge life effect and cost, that boundary isn't at 15% anymore. It's actually
yeah,
at 90%. There's a 90% chance that I will do
something.
something assuming it's cancer because the cost of it is so high. And there's two frames of seeing it, and I think it's a typically more of a Bayesian frame to start changing your boundary as a direct result of the cost of being
So I kind of wonder here, because this will lead nicely into our next section
wrong. Yeah,
about using Bayes' law versus doing Bayesian inference,
yeah,
right? In the paper, they walked through Bayes' law, right? And they got to the 15%.
yeah.
But arguably, the Bayesian inference occurred after that. There was some, uh, they took those numbers and said, whether they did this in real time or not, but they took those numbers from Bayes' law and they did inference on that to determine that my decision boundary was not going to be 50% or 70%. It was going to be something low that like could be 1% in that case, 1% probability of being pancreatic cancer, and there's still an action that the clinicians decided, based on their inference, to do something about. Um, so, so that being said, um, that being said,
This kind of split between the Bayesian calculations versus
yes,
the
the Bayesian
Bayesian decision making.
exactly, and
Yeah,
and kind of and where is there a way to? Because clearly, I think the paper argues it's even pretty difficult to just formalize the first part. just doing Bayes' law, it's not like even that first step is easy to do, like at a high throughput level
Yeah.
on the wards, right? And then,
Yeah.
like we said, like even as humans, are we just doing low, medium, high? We're not even getting 15%. We're not even doing, like in the paper, it's computed, but in real life, no one was sitting there saying, 15% given all these findings, right? So,
Yeah.
so given that we're not even getting past that first step, right?
Yeah. Yeah.
How much are we compounding the problem here of doing Bayesian inference when we can't even compute Bayes' law
Yeah.
even accurately up front?
And I love that you said that because I don't think we've necessarily talked about this before, but a big argument I always got is, if Bayes' law is so good, why are we not using it? And I got this a lot in the early 2010s, right? So early on, it just made sense. I loved everything about the kind of Bayes way of thinking. But if it's so great, as you say,
Yeah.
why is no one using it? At the end of the day, we'll have maybe a separate podcast where we talk about the math a little bit more. But following Bayes' law, the kind of P of A given B equals P of B given A, that calculation, actually in any real world model, is so high dimensional that you have to calculate these things that are actually really, really, really tough to calculate. They're
Yeah.
incredibly tough to calculate. The denominator of Bayes' law is notoriously hard to calculate.
Yes.
And then computers and machine learning and deep learning showed up.
Yeah.
And all of these approaches give us a way to offload those really, really tough calculations to the computer. And
Yeah.
we'll talk about this, I think,
Yeah.
right at the tail end of this. They can calculate those things way better than anything else historically.
Yes.
We've never done those calculations. Like literally, we don't do it
Yeah.
in our brains, really, not cognitively, maybe on the neural circuit level, but we just don't do those calculations because until 10 years ago, computers couldn't do it. We couldn't do it by hand.
Yeah.
Versus the Bayesian inference, Bayesian decision-making part of it. I would argue we've been doing that the entire time. What are your thoughts?
Yeah. No, I think, I would love to talk about like MCMC, when it comes to computing some of these, because even in today's world, those are still hard for computers to do as well. Those are not computationally, efficient problems to solve, right? To compute the denominator of the of Bayes' law.
Yeah.
That being said, I think what we're getting to is in this last part is, if there is what I think has happened is, so MDCalc, very popular tool on the wards. It's, when you're on medicine, it's great to have in your note, like a computer probability of this given this set of criteria, right? And we can put into our note that, like, given these lab findings, probability of let's say sepsis, right, is 40%, right? And we're trying to really get something very solid that we can kind of like, we can put our finger on and say, this is what I'm going to act on. Mm-hmm. What I think is, and I love MDCalc. I use it. I love using it. But what I think, how it's being misused, and we can discuss this, is it being used to do Bayesian inference, or and is that correct? Versus, is it being used to supplement our Bayesian inference?
Yeah.
I don't know if you want to.
Yeah, absolutely. I think the cornerstone of Bayesian inference is, you come in, you tell me what your prior is. What are you coming in with? We're starting a conversation, but we're not starting from scratch.
Yes.
Tell me what you're starting with. And then we can work through how to update that with the data that comes streaming in. So in that context, it's fascinating because these tools, there's a lot of different ways of looking at it, but that prior is a starting point. And MDCalc and these tools are great ways to feed into that starting point, right? Are you using these tools in a way that is building your prior, or, and I would argue, and I think we would agree, but we can discuss this, or are you misusing MDCalc to calculate your posterior, or calculate the end thing that you're going to make decisions off of? Because I would argue MDCalc is not meant to do Bayesian inference. It's meant
Mm.
to calculate Bayes' law, Bayes' theorem on some inputs that these guidelines tell you, and it then spits out a prior that lets you work with it in a formal way. I don't know. What are your thoughts?
Yeah, I think it's. I mean, I'm looking at. Sorry, I'm looking at one of so the search criteria, right, is really popular for. It's one of the older ones. There's a newer one called QSOFA, but this one is one of the very classical criteria that you use to determine someone is, is septic, right? And there's only 4 inputs. It's temperature being above or below a certain point, heart rate being above a certain point, respiratory rate being above a certain point, or PaC2 being below a certain point, and then a white blood count being either too high or too low.
Yeah.
And if you get more than 2 of these or greater than equal to 2 of these, you meet search criteria. And the MD-Cal, it's great. You take your patient for your data, and it kind of spits back at your probability, and then you can decide kind of how to interpret that.
Yeah.
By we were I could easily, as a healthy human being, meet all these criteria. I can go exercise and go on a hot day. I could meet search criteria and be completely healthy and not be septic, right?
Yeah.
So this is like a great example of where where the prior, depending on how you want to view it, either the prior is some clinical presentation that 31-year-old male who is feeling great and just went for a run, is what's a prior of that person being septic? Probably very, very low.
Yeah.
And therefore this tool is not going to be very, very helpful in upping the.
I love that example, because what's also in your prior that we didn't mention is, in what setting am I seeing you at? Am I seeing you in the living room of your house and you have these criteria? Or am I seeing you in the ED and I'm seeing these criteria? Because that is in the criteria.
Yes.
It's never mentioned, but where you see this person is in the criteria. If you see them in the hospital, use this. If you don't see them in the hospital and you use it, what is it meant to tell you? It's not really validated in telling you anything.
Exactly.
So if you use that as a posterior, well, there you go.
Exactly. Exactly. So I think there's so much. There's these tools. I think a lot of weight is put on them.
Yeah.
And I think because as doctors, we are overwhelmed with the volume of patients we see. Like the article mentioned, someone cannot be doing Bayesian inference, days on days for 22 patients. Yeah. So we want to offload. We want to offload some of that cognitive burden onto, a computer, right? In some way, shape, or form. And that's kind of an MD calculus, kind of one way of taking some of that cognitive burden and putting it on something else, right? And I think the problem there is while it's helpful, over reliance on it can be clearly problematic.
Yeah.
Right.
Yeah.
I think this really highlights our discussion today. Maybe to summarize, the last thing I'll add to the conversation is that yes, Bayes' law in itself difficult to compute at high throughput. I think things like MD-Calc, and I think as AI and machine learning begin to kind of take off in this field, they will greatly assist us in being to compute some of these things. Whether they will get to a level in our lifetimes where they're truly doing Bayesian inference, which means that they're able to adjust model parameters on the fly, right? They're able to wait. How much does the heart rate matter in this patient, right? Mm-hmm. Given what I'm seeing, will it get to that point in our lifetimes? I like to think so. I hope so. Yeah. But until it does get there, right, we cannot treat these computers and models like they are doing that. Like they are learning. They are taking into account, context. They're not. And I think that is the important thing that I see as being a problem as we begin to incorporate machine learning and AI into clinical reasoning, is to understand their limitations, and that we are the inference engine. At this point, these are merely just computing mathematical functions for us at this time.
inputs into our decision making,
Yeah.
and that's something I'd like to see, and I think we see it, but clinicians and med students trust your judgment, and work on your judgment, work on your inference portion of it. Use these tools, bring them in, learn how to deal with them, but at the end of the day, you are the physician. You're the one who's calculating. Just to tie it back to our beginning of the discussion, you know the cost of that adenocarcinoma to that patient because you're compassionate. You ask them what else is happening. Do they
Hmm.
have grandkids, right? Like,
Hmm.
I want to see my grandkids do something.
Hmm.
Well, the cost of that adenocarcinoma and missing that adenocarcinoma is very different
Hmm.
versus you're the one integrating all those concepts. And it's really, really tough to measure those. And if somehow magically we figure out a way to measure those, it's a whole nother thing to come up with guidelines that know how to crunch the numbers with those, right? Those are two separate issues that we're not anywhere close to dealing with. So we'll probably save this for a future discussion since
Yes.
we're kind of wrapping up, but I stay tuned. Maybe it's a bit of a, hey, this will be what we'll talk about next time. But I would love to explore the idea of Bayesian inference, Bayes theorem, and reverse engineering. And this
Hmm.
idea that we're making decisions and we want to understand why we made those decisions. We're making these therapeutic decisions and they are working, but how do we then backtrack why they worked? And why I think that's relevant is try to, for whoever's listening, try to avoid doing MD Calc,
Hmm.
seeing what it says, and then backtracking to say, yeah, that makes sense based
Hmm.
off of the things I
Hmm.
saw with these patients, because that's reverse engineering, and you're reverse engineering a decision you did not make. You're
Hmm.
reverse engineering a decision that was given to you, and you're then backtracking to figure out which pieces of evidence that you have support the MD Calc output. I'm not saying anyone's
Yeah.
doing this.
Yeah.
I've seen some close calls, but that's a very different framework. And this is what I think we mean by Bayesian inference. It's a very different framework than you making the inference off of MD Calc's calculation that comes into your decision making, along with the symptoms, along with the labs, along with
Yeah.
everything else. Because at the end of the day, you made that decision. That's a forward decision.
Yeah.
That's not a reverse decision.
It sounds like what you're saying is the goal of all this is to update our own models, is to
Yeah.
train our own models, and how to do so in an efficient and effective manner. Um,
That's a point of discussion. Some people
yeah.
disagree with me.
At least it sounds like the hope of the
Yeah.
process.
Yeah.
This was great. I think this is. Stay tuned for more of these discussions. If you like this, or you want to see something different, or things are not clear, or of course, we're open to any ways we can improve this and provide whatever people want to hear.
Yeah. Feel free
It's
to reach
helpful.
out to us. Feel free to reach out to us whenever, and we'll try to do this a little bit more often and a little bit more little nuggets that are digestible.
Agreed.
Awesome.
It was
All right.
fun.
Pleasure as always.
Take care.
You too.